Good morning, everybody. My name is Vasudha Goyal. I'm an anesthesiologist and pain management physician at the University of Minnesota and faculty at the American Society of Regional Anesthesia, also known as ASRA. I have the personal fortune of inviting and interviewing Dr. Henrik Kehlet, who received the Gaston Labat Award in 2005. He's a most well-known surgeon amongst anesthesiologists around the world due to his substantial contributions towards the understanding of surgical pathophysiology. Around the same time, he was a professor of perioperative therapy and head of the section for surgical pathophysiology at the Rigshospitalet in Copenhagen. He's a prolific writer, having authored over 950 scientific articles and holds an H-index of over 80. He has received numerous honorary awards from distinguished learned societies such as the Royal College of Anesthetists of Great Britain and the American College of Surgeons and American Surgical Association. He has also been invited worldwide for numerous lectures and has given revered lectures, including the Labat Lecture, Bonica Lecture, the Carl Kohler Lecture, and the Simpson Memorial Lecture. This interview is a part of the activity surrounding the 100th anniversary of the founding of the first American Society of Regional Anesthesia in 1923 by Gaston Labat and colleagues. Although this organization is not related to the current day ASRA Pain Medicine, which was founded in 1975, it has been said that the current society would not have existed quite like it does without the work of Dr. Labat and the original ASRA. I would love to welcome Dr. Henrik Kehlet this morning, and we will proceed with the interview. Good morning, Dr. Kehlet.
Thank you so much, Vasudha. I'm really happy to participate, despite that it is so many years ago since we had the meeting in Toronto. Thank you.
It's a pleasure, and I'm grateful
really
for the opportunity to interview you this morning.
Yeah.
So I'd like to start with when you first chose the field of regional anesthesia. Could you please share with our viewers and listeners what led you to choose the field of regional anesthesia?
Well, as a young surgeon, when I did my first major operations, I was really sad to see that some patients died of a pulmonary embolism, liver failure, etc., independent of the surgical technique. Mm-hmm. And then I became interested in what are the reasons for postoperative complications. Mm-hmm. And it turned out to be really complicated, but the main mechanism was the surgical stress response. And therefore, I became immediately interested in blocking these afferent impulses to the central nervous system, releasing the endocrine metabolic response to surgery. And that was a start for my interest in regional anesthesia. Also because of the need for better pain management. Mm-hmm.
How did this lead you to hypothesize on multimodal analgesic approach? Can you elaborate, please?
Because when we develop very effective regional anesthetic techniques to block these responses and to improve pain management, I expected patients to jump out of bed and go home much earlier, but mm-hmm. nothing happened. Mm-hmm. Because postoperative recovery is multifactorial. Mm-hmm. So then we had to focus on fluid management, especially on nursing care, on all the surgical care principles with unnecessary use of nasogastric tubes, drains, type of incisions, minimally invasive surgery. So it all became really complicated because in the beginning it was too simple about pain management and blocking the catabolic response to surgery.
Mm-hmm. What were the predominant issues of the field at the time when you started?
I think at that time we were quite narrow-minded in some way, because we thought it would be very simple, pain management and regional anesthetic techniques. And it turned out to be so complicated, but that's still fascinating, because my main interest in the beginning was the surgical stress responses, which is not only the endocrine metabolic response, but also these inflammatory and immunological responses. And that turns out now to be the biggest challenge to improve recovery.
So I understand that you were effective in transforming the way perioperative analgesia is administered today. Can you share with our viewers how the field evolved over your career?
It evolved because of the realization that it is a multifactorial problem. And I would say pain management and minimal invasive surgery, that's probably the two most important components. But usually I get the question, what is most important? And it is not one thing. That's the key problem. It is a multifactorial problem. And still 25 years or even more after we developed this approach with enhanced recovery, there's still so much struggle to implement scientific evidence. I mean, you would expect that when things were documented and it was fantastic, that people would just do it. But it turned out that they would not always do it. And it is still a problem to implement scientific evidence. That means closing the knowing-doing gap. You see that all the time, that it's difficult to implement scientific evidence, which is unfortunate, because the whole approach of enhanced recovery has provided a major benefit to patients, and also to the health economics, because you save a lot of money. So there are two problems, main problem. One is to understand the pathophysiology of surgical recovery. And the other one is the whole organizational issue, how to do what you should do. The most important is to have an open mind and challenge traditions in perioperative care. Ask the question, why, and why? So it all started by asking the question, why is the patient in hospital today? Why couldn't we do any operation on an outpatient basis? Of course, we cannot do all the big operations ambulatory, but it's moving. But by asking the question, and that's for the young generation, ask the questions, why are we doing this? And the next thing, of course, is how can we improve? How can we control the undesirable responses to surgery? And I would say a major challenge now is really to understand the individual responses to surgery, because we now realize from several places in the world that patients are not patients. We cannot lump patients together in studies. We have to separate, for instance, between high pain responders and normal pain responders. We have to separate between patients who have a hyper-inflammatory response versus those with a lower response, because they have to be handled differently in the clinical treatment, but also in the research environment. So there are many challenges, and I hope the young generation will continue to ask these questions. Because when I was young in surgery, I mean, the chief surgeons, they were kings. What they said was the law.
Mhm.
But nowadays, we are lucky we have a more open discussion, but we still need to have it.
Mhm. I think you summarize it really well by saying that we need to ask the two fundamental questions: why is something happening, and how can we change it or improve it, improve that condition? Thank you.
Yeah.
I would like to ask how your career evolved from studying surgical stress response to then working on preemptive analgesia, and then to fast tracking patients for surgery.
In the beginning, we had this question about these undesirable surgical stress responses, but we also had the clinical problem of pain management. And then it was important to realize that when you have to provide pain management, it has to be effective when the patient wakes up. So we cannot start after surgery.
Mhm.
And then it's Patrick Wall in London and Clifford Wolf. They did these interesting experiments in rats that if you initiated the neural blockades before the injury, it was easier post-injury to handle these animals. And it was a fantastic theory, but it turned out not to be realistic in surgical patients because, as we showed many times, a short-term anesthetic intervention will not solve the problem because the responses, they continue. So therefore, it has to be a type of double attack. You have to start early so that it is effective when the patient wakes up, but you also have to continue because the responses continue. So that's also, we still have that debate about spinal anesthesia versus general anesthesia, for instance, for hip fracture. For me, it has no meaning at all because these patients, they have so many problems after the spinal wears off, and that is where we have to attack the problem. You cannot solve it by giving a single shot of something. But that's still controversial because the discussion goes on with spinal versus general or blocks versus no blocks. We have, again, to have an open mind and understand the full picture of the pathophysiology of recovery. And we have to do more studies now that hospital stay has decreased tremendously. We have to focus on the post-discharge period. And here there are many black spots because the patients still have inflammatory responses. They still have pain. And we have too few studies on pain management after the first 1 or 2 days. So this is a huge challenge.
What was your initial reaction to the news that you had received the Labat Award?
I felt so honored because as a surgeon to receive this fantastic award, it was, beyond my imagination. But I was so grateful because I had so many good friends in regional anesthesia. Even being a very young surgeon, I knew all these world famous people in regional anesthesia. It was fantastic for me because I learned so much about the physiology of pain. Because regional anesthesia is still a major component of care, of course. but it was a surprise for me as a surgeon to get this award.
Congratulations again. I mean, it's been a while since you got the Labat Award, and it's amazing that you do so much work in the field of perioperative pain. I just see your whole face light up as you answered that question. So, what changes in thinking, practice, and/or perspective did you foster during your career?
That's a difficult question because, again, if you're interested in surgical outcome and how to improve, it's so multifactorial. You jump with your research focus from pain to inflammation to fluid management to sympathetic nervous system physiology, and that is so fascinating, and it's still so fascinating because we haven't solved the problem completely. We have improved a lot all over the world, but it is still dangerous to have a major operation. It is.
What would you recommend our viewers, young physicians, and scientists? It is a multifactorial problem, and it can be daunting to work in this field. What would you suggest to our viewers on how to continue moving forward in this area?
Of course I will, but I have to admit it has become more complicated for many reasons. We know the pathophysiology of recovery in more detail, and it's really complicated. I think if you're a clinician, a young clinician, it's quite obvious that we have these fascinating challenges about surgical recovery, because if you provide optimal anesthesia and surgery during the operation, why should we have all these problems post-operatively? It's a fascinating challenge.
Dr. Kehlet, who do you consider were your greatest mentors as you did all this work in perioperative care?
I think from the surgical side, it was Douglas Wilmore in Boston, who introduced me to the surgical stress response, the complexity of that. And from the anesthetic side, I think it was Phil Bromwich and Ben Covino, who introduced me to regional anesthesia and the physiology. Phil Bromwich, he did some fantastic studies on epidural anesthesia, and I was lucky to meet him also in his home to learn a lot about regional anesthesia and the influence on the autonomic nervous system and endocrine metabolic responses, etc. It was fantastic.
Were there any challenges in collaborating with mentors from different specialties?
No, I think the difficulties, as I mentioned before, has not been with the mentors and collaborators. It has been with the implementation of the scientific results. That has been disappointing. I mean, when we published, even in the Lancet in 1995, that you could have open colonic resection with a 2 to 3 days stay in high-risk patients, we can still see publications now in 2022 where length of stay is 6-7 days in national surveys. So that's the challenge, but never any problems with mentors or collaborators, no. we have all realized that that there is an increase in fraud. So if you read something, it may not always be true. That's another challenge. And that's one of the reasons why it has to take some time until new science is translated into clinical practice. If we talk about clinical care, there are so many people involved, and if you have some new findings, it has to be confirmed by other people in other circumstances, etc. Because if you show something in Scandinavia, it may not be applied to India or everywhere. I remember in the beginning, people were resistant, also in US, because these data from Scandinavian people said, "Oh, these are Vikings." It may not apply to US, but it did. Yeah.
What words would you choose to define the American Society of Regional Anesthesia, commonly said ASRA?
Well, it has had a leading role in our understanding of the importance of regional anesthesia. It's so important, it's crucially important. And as I said before, most of my mentors in regional anesthesia, they were from US and ASRA.
Thank you, Dr. Kehlet. It's been a pleasure meeting you on this platform created by ASRA today. Thank you for sharing your experience with your long career and immense number of achievements. I've enjoyed interviewing you today, and I hope our viewers and listeners will enjoy this series that we have created for the 100th anniversary of ASRA. Thank you very much.
Thank you so much.